Hello, I am Josh Knackert, here to provide session two of XCenter's challenges across the care continuum with a focus on what patients face for rare disease. For disclosures, I've included the companies that I am working with at this time. However, all of these statements are my own and do not represent any of the organizations I work with. Additionally, I'm not a medical professional, and none of the following constitutes medical advice or care. Learning objectives for this session include illuminating the lived experience and systemic barriers for rare disease patients and caregivers, understanding the reasons behind the disproportionate rare disease burden on children, identifying the multiple potential barriers of diagnosis for rare disease, as well as recognizing the psychosocial aspects of a patient's journey with their rare disease, as well as that of their caregiver. You can see the agenda here of what we'll walk through. For my background, my technical experience started as a researcher in the basic sciences. I worked primarily in neurodevelopment, human stem cells, and cellular biology. After doing that for a number of years, primarily at the UW-Madison, University of Wisconsin-Madison, as well as some companies, I pivoted more towards science communication and outreach. I worked as a science journalist and educator. This picture is actually me performing or demonstrating a interactive display that I built with a group of school children. The display is showing how human pluripotent stem cells can differentiate into all these different tissue types in the human body. From there, I took that kind of mixed experience of being both a technical researcher, trained researcher, and a communicator of the technical into the commercial sector more full time. I have worked for a number of years now in pharma, biotechnology, and health sciences organizations as a consultant and executive in a variety of sizes and working on a variety of indications, including cancer, nephrology, and other areas of human disease. My technical background includes a master's in cellular and molecular pathology and a bachelor's in microbiology, both from the University of Wisconsin-Madison. My personal experience with rare disease is lifelong. I am a rare disease patient for a disorder called nephrogenic diabetes insipidus. And what you're seeing here is the V2R protein, which is the protein that is mutated in the congenital X-linked form of NDI, which is the shorthand for that disease. It's a bit of an unusual amalgam of mutations. There are more than 200 known mutations that all cause largely congenital NDI, all on this protein here. In this situation, the mutated protein means that it doesn't bind correctly to a normal kind of hormone in the body, and it misregulates concentration within the kidney. So it is a nephrology or kidney disorder. But what is nephrogenic diabetes or NDI more specifically? It is a rare disorder affecting the kidney's ability to concentrate urine. So basically, when that protein that we just talked about is mutated, the antidiuretic hormone or vasopressin is unable to bind it successfully. And in the usual setting, when that hormone binds, the protein then causes a cascade within the cells of the kidney and moves a key aquaporin or water channel into the cell membrane of the kidney. That water channel is responsible for the reabsorption of water as urine is being processed through the nephron, which is the functional unit of the kidney. So what happens is in NDI, patients cannot concentrate water in their kidney. And so typically what the kidney is trying to do is pull the water back out to rehydrate the body and concentrate out the solutes, so things like salts and other electrolytes or toxins that it's trying to get out of the body, pharmaceuticals, urea, other things like that. However, in an NDI patient, all of those things still exit the body, but they exit with basically the full volume of water. There is not much reconcentration, which means that the body is constantly dehydrating itself in an incredibly intense manner, which means that there's large excess of urination as well as large excess of thirst to make up for this dehydration, leading patients to drink something like 4 to 5 gallons of water a day in the adult indication of the disease, or adult phase, I should say. This is distinct from a similar but different disease in central diabetes insipidus. That version lacks the hormone itself, so the hormone is not produced in the brain. And those patients are able to supplement the hormone through a nasal spray. So there is a treatment available, and they are able to regulate the concentration in their kidneys much more uh, realistically or close to average because of the replacement of the hormone. However, NDI, in general, NDI, nephrogenic diabetes insipidus, does not have a treatment on market at this point. I I did also include the picture here of Shaq with the water bottle because as an NDI patient, no water bottle ever seems large enough for us. Obviously, you're constantly keeping an eye out for more water, carrying huge amounts with you to stay hydrated throughout the day. From a diagnosis perspective, spontaneous cases of NDI are caught within health systems typically at about 3 months of age. That's because at that phase in an infant's life, the kidneys are finaling their maturation and are functioning in what would be kind of their normal manner. And that's where we start to see the lack of concentration happening in these kids. The challenge to this is that it presents in a manner that would be commonly seen in a variety of other causes, which is very true for a lot of rare diseases, as we'll talk about here later. Patients come in with things like failure to thrive, dehydration, electrolyte imbalance, and other GI issues. These are often attributed to a variety of other more likely causes, and it can delay the diagnosis of these spontaneous patients. This this poses a particularly challenging uh, time in the life of the patient because if an individual has intense bouts and repeated bouts of dehydration, it can lead to quite a few and very intense secondary implications. Things like seizures and coma, permanent brain damage, developmental delays, and cognitive impairment. This was very associated with this disease in the past when we weren't knowing what we were looking for, when it wasn't well documented in the literature. This would happen to these patients with regularity because they were not being hydrated at this young age and they were having these problems. From a known familial perspective, as I said, this is a genetic disease. When a known case is present in the family, it can be a little bit easier or more likely to catch those diagnoses earlier. And that's because if you know to send in a screening for the child, if you know to send in an NDI or a broader nephrology panel, you can catch the mutation and understand very early if the child does or does not have the disease, potentially even before the kidneys fully mature. So clearly, genetic screening is an incredible benefit, as is the case for many rare diseases. However, this is not proactively on any genetic screening panels in the US and in any of the states at the current time. So, as I said, I have a very personal course with a rare disease. I've lived with them my whole life. No caregivers, it runs in my family. And so it does give me the perspective to speak to rare disease. However, as we'll go into much deeper here, rare disease is incredibly diverse. So it's a large pool of people, but there's something like, in some estimates, more than 10,000 distinct rare and genetic disorders that present as the full pool of rare disease. So what I will attempt to do in this presentation is speak to the patient experience in as broad and general strokes as I can, while also fully acknowledging that even within an individual disease, individual patients can manifest quite differently. And the huge spectrum of rare diseases means that while many of these things are largely true, each disease, each individual is going to have a very different level of severity for some of the things we're talking about here, or level of reality in terms of how the rare disease impacts their life. But that being said, rare disease is common as a pool, right? It's 1 in 10 people are affected by a rare disease, with 8 in 10 of those rare diseases having a genetic component. One of the key challenges is because the rare disease as an individual disease is usually such a very small population, there are not very many approved treatments on market. There's not a large patient population present to justify or to kind of drive the economics of therapeutic development. So unfortunately, at this time, we only see something like 5% of rare diseases with a FDA-approved treatment on market. As we'll go into detail a little bit more, rare disease is particularly prevalent and kind of heavy in children in terms of its impact. 7 in 10 rare diseases occur in childhood. And as we've talked about a little bit, and we'll open up more here, it is often a very long diagnosis. As we talked about within NDI, and is true very often within rare disease, it takes a very long time, years usually, 6+ years on average, for an individual to get their full final diagnosis, especially when it comes to being one of these rare disorders. And yeah, both before the diagnosis and after, the economic impact to the patient and the caregiver is immense when it comes to rare disease. So for some big picture challenges, as we talked about, it's 1 in 10 people, but it's 10,000 unique diseases, meaning that manifestation, treatments, and experiences are incredibly unique at every level of the disease and at every phase of the disease. It is incredibly under-recognized and underfunded. So total direct yearly medical costs approximate about 400 billion in the US, which is similar in annual direct medical costs for something like cancer or heart failure or Alzheimer's disease. Clearly, much more commonly known terms, much larger investments and level of interest from a research perspective and a therapeutic and a healthcare perspective. And much of that comes down to the uniqueness and the variety of rare disease, but it is still an immense level of financial burden on the healthcare system. Less than 0.1% of the NIH, the National Institutes of Health annual budget, is allocated to rare disease research, making it a very scant and incredibly small portion of funding from an R&D perspective. But there is an immense therapeutic gap present. Like we talked about, somewhere between 90 to 95% of rare diseases have no treatment currently on market. So you have a huge amount of patients, many, many millions of people looking at no therapy for their current disease. There is a disproportionate burden on children when it comes to rare disease. Almost 70% of rare diseases present in childhood, and but about 30% of children with a rare disease will die before the age of 5 years. Much of this is due to the fact that there is, that it may take quite a long time for the rare disease to be fully diagnosed and caught. There's a lack of therapeutics, there's a lack of understanding. And so all of those things can lead to complications or delayed diagnosis or all of the things that come with the challenges for especially an infant to have a rare disease and all of the things that come with that. Children are estimated to make up half the patients with rare diseases. And when you look at the higher level numbers, 6% of live births are affected by a genetic or a congenital anomaly, which is often associated but not necessarily fully aligned with rare disease. But 30 to 50% of neonatal and pediatric admissions are due to birth defects and genetic conditions, with 40% of NICU deaths related to rare genetic diseases. And it's clearly an immense cost to both the hospital system and the patient in these situations. So there is an immense burden on both pediatrics and children with the disease, as well as pediatric care, and how much it demands of those specialists and of those divisions to care for these patients in the best way they can, which currently has quite a few gaps. So we talked about the fact that the diagnostic odyssey, which is the process by which a rare disease patient comes to their kind of full and final diagnosis, can be very long. And like we talked about, is often on an average of more than 6 years to get that diagnosis. So when you think about these patients dying before the age of 5, hopefully all of them have diagnosis. Some of them don't find out until at autopsy or later, right? Because a sibling has it later down the road, or the family finds out and finds a diagnosis in another manner. So the diagnostic odyssey is elongated for a number of reasons. A lot of them come down to lack of knowledge about the disease at many, many levels, from the health system to the insurer to the provider to clearly patients themselves. That comes along with its own implicit biases and challenges to navigating the healthcare system. And as we've talked about here, there's one of the biggest challenges to diagnosing a rare disease is that many of them will often present in a manner that is overlapping or very common to other more likely challenges or more likely diagnoses. And so you get these disease presentations that can look like something else, or it is challenging to elucidate the full picture of the disease quickly, right? To understand what are all the symptoms? What are all the implications? Maybe they don't all manifest at once. Maybe they come and go, right? And so that variability is inherent to the challenge of getting a clear diagnosis, and that comes with repeated tests, inaccurate tests, misdiagnoses where you can go years thinking you have another disease, being treated for another disease, only to find out that that treatment may have been doing nothing for you, or that you've truly had something, and or that you've truly had something else this whole time. Along with just access is a big thing that we'll talk about here, and it's always the case in healthcare. We're not talking about, in rare disease patients, you have people who have to have many diverse touch points with the health system just to get to their diagnosis, and then that continues through the rest of their life from a care perspective. There is an immense opportunity in getting to that faster diagnosis. There is a lot of cost to patients, ranging from anywhere between 80,000 to $500,000 in a cumulative estimate for avoidable costs attributed to delayed diagnosis in rare disease. That's a huge amount of money that is often coming, you're not going to get back because insurers aren't going to go back and pay for it before diagnosis. And so timely diagnosis not only means that huge financial savings, but you could be getting to a prompt life-saving, more prompt access to life-saving treatment if one exists, or at least life-improving treatment if one exists. There's a huge amount of time in this process, right? Especially if you don't have a full diagnosis to the point where you can claim missed time or needed care or support. If you're truly doing this because you're still on your path, you're not going to get financial or recognition in many of these cases. And so that leads to missed work and increased healthcare visits, often with travel and coordination and the like. And there's many other direct and indirect benefits for patients, caregivers, and families the sooner that this diagnosis can come to the patient. And we know from research that the final diagnosis improves the quality of life for parents whose children have a disability, which many rare diseases are at the level of a disability. And so this elongated diagnostic odyssey weighs on kind of everyone involved in the care and coordination of this patient. So when we talk about healthcare from rare disease, what does that look like in terms of the challenges and the reality? When it comes down to barriers of care, this is some of the highest reported elements from rare disease patients when it came to what are barriers to getting their care. A lot of it comes down to being overwhelmed, a huge amount of stress and kind of inability to self-motivate or to be in a state, a physical or psychological state to do all of the things that are needed of you, whether it's to physically get to the appointments, to coordinate the appointments, to coordinate the communication that's required across the many parties. And some of that's due to just the nature of the disease itself. As we talked about, well, it can also come down to being able to afford or having it be covered, right? That's a huge access piece for a lot of patients, both before and after diagnosis. We'll get into more here. There is also a challenge to getting a provider to listen and understand and not dismiss the element, being a rare disease patient if you are diagnosed, or kind of going down that diagnostic journey and being persistent in figuring out what you actually have when you don't feel like you truly understand the disease, or that you truly understand what's going on. And that shows in a variety of reports by these patients. When it comes to the medical systems and medical providers themselves, there is a key lack of awareness on rare disease. Many rare disease patients and their caregivers report that they often know far more about their disease and certainly their individual care than a specialist, and certainly a generalist in terms of a healthcare provider. They both patients and caregivers put this lack of awareness and information available as one of the top, if not the top, challenges to kind of navigating medical care for rare disease patients. And they often have to then go and educate those medical professionals about every level of their diseases. And this is, often because even for a specialist, you may have only, as a medical professional, been trained on this one rare disease it could have encompassed, a single mention or a single paragraph in your entire medical training. And so some of this is very understandable in the fact that nobody's going to think that they're an expert on something that they read one paragraph about, right? And so some of this comes down to they didn't, there's only so many things they can be trained on, and there's only so many things they're going to see. And oftentimes, these patients are the first time or maybe the only time that that specialist will ever see that specific disease. And so there is a distinct barrier there in how quickly can that doctor and persistently can that doctor kind of come up to speed on that disease. And patients or physicians are clearly trained to work their way through the most likely causes, right? You first have to knock down the things that are more common in terms of overlapping symptoms or similar diagnoses, and rare disease is often at the end of that process. That's why the National Organization of Rare Diseases, their mascot is the zebra, because the saying they like to always trumpet, which I think is very accurate, is when you hear hoofbeats, you think horse, you don't think zebra. And I think the challenge to that is we have to encourage providers to take a more holistic view than just listening for the hoofbeats, right? You need to earlier on try to extract the fuller picture, right? Run a more comprehensive battery of tests to start to look at a wider variety of where the causes for these diseases could be coming from. And unfortunately, patients report being dismissed. Things like being told their symptoms are psychological, the patient themselves are labeled as difficult, and that can really fly in the face of trying to be persistent in a diagnostic odyssey or trying to be persistent in gaining the care that you deserve that is needed for this disease. So when it comes to recognizing rare, some of the recommendations or kind of flags for a potential rare disease are multi-system involvement. So, more multiple systems in the body. So does this disease have a neurological and an immune component, or, something like a GI and a cardiac component, right? When you're starting to get into these multi-system diseases, that starts to suggest there's something, foundational at play there, or something bigger. Is there a genetic inheritance pattern? Right? Are there other members of the family that have some or all of the manifestations of this disease that would suggest a genetic heritability of something that's going on? Do the symptoms continue to present through childhood and adulthood, and do they come and go? That's one of these things where it's like they're not growing out of a disease, as we hear, right? This is persistent, and this is something that's staying with them as truly life affecting for potentially all of their lives. Are they seeing difficulties in school, things like absences, challenges participating in physical education, bullying, or social isolation, right? These are kind of secondary effects that are likely, related to a larger disorder. Have they seen multiple specialists? This goes with the multiple system piece, right? Do they have a record of seeing multiple specialists and not getting kind of a full diagnosis, or not seeing that story kind of brought together holistically? And is there an extended period with unexplained symptoms, or one or more misdiagnoses, right? That is another indicator that they're on some type of odyssey. Understanding, coordinating, and advocating through this journey are incredibly essential. But as we talked about, that challenge and that task falls disproportionately on patients and caregivers to stay persistent, to educate themselves, and to navigate. So rare disease patients, like all of us, are come up against one of the key challenges within medical care right now, and the fact that it is often very fragmented, and that even though we've moved towards medical health record, electronic health records in the last few decades, there's still a shocking lack of coordination and communication across individual providers, systems, and the like. They typically, rare disease patients especially, require care from numerous providers, specialists, likely across health systems. And unfortunately, there's poor information flow there. Electronic health records can be in different formats. There's a lack of automation in terms of sending and accessing those across systems or providers, and it's often very siloed. And so that leads to breakage in continuation or communication across parties that really need to be collaborating on the diagnosis and care for these patients. Many systems don't have care coordinators that even when you're in a single system will kind of pull all of these threads together, or make sure that the various stakeholders involved have the full picture and have the full amount of data even within the system. And so again, patients and caregivers are having to step into that role and manage that kind of effort to make sure that happens. They're forced to manage records, appointments, and continuity kind of across this continuum of providers' care. And it often leads to things like duplicate tests, contradictory treatments, missed follow-ups, all of the things that happen, at a low rate normally are going to happen more often, especially with kind of the complexity and confusion that comes with rare disease. And rare disease patients are far more likely to get unnecessary repeat tests, and it can really lead to negative health outcomes for these patients. They have to go use emergency care more often. There's medication errors, lack of understanding, confusion, and just poor transitions between the various groups that need to be kind of trying to do this in sync with each other. So clearly, this insists that the patient and their caregiver often have to act as the disease expert, and they typically have the most awareness. They have to educate every medical professional involved and kind of correct them oftentimes, which is a daunting task to do. Like I said, they must play the role of care coordinator pretty much at all times across varying levels of systems and providers. They always are asking for more information. It allows a patient or a caregiver to better understand the disease, what they can expect. How do you cope with the challenges? How do you anticipate the challenges of the disease? And that is limit in information was the most frequently cited need, kind of issue or need of parents of people with rare diseases, right? Everybody in the space wishes there was more. And the challenge is it's often more about their rare disease, right? Which is even harder to come by. That is, as we've said, incredibly unique, very individualistic. And so you often have to look to communities of peers to get anything that is accessible in that space. They also have to go against this kind of a common challenge in the fact that there's a belief that there's a refusal of patients and caregivers to help overcome the limits of their knowledge. And personally, from my own experience, I can tell you that I don't think that's further from the truth. This is a population of people that is constantly seeking out new information. They're so involved in their own care and in monitoring kind of the state of the art and the state of research at a level that is immensely higher than your average patient. I mean, these are people that are having to go read scientific papers and research studies and clinical trial protocols. This is stuff that I went to school for years to be able to do, to be comfortable to do. And, you have lay people within the rare disease space who are self-training on some of these things, who are the ones driving the conversation with providers, who are sharing knowledge and new information with each other because it's the only way that it's going to happen. And so this idea that the vast majority of patients and caregivers in this space are not spending huge amounts of time and energy and just what they have to seek out this information is not true. Um, and that lack of knowledge and treatment really puts caregivers and patients in a bind, and it makes them feel like they have to take whatever they can get, right? Even if that means it's not an approved treatment. And that often will come with a lack of coverage, right? If it's not an approved treatment, health insurance is likely to not going to cover it. And many of those treatments can either come with intense side effects. So now you're talking about additional symptoms or things to manage within the disease, or they can wear off over time, right? There can be a level of the body adjusting to the dose and then not being able to go up or just not having it be effective. And so many of these treatments are just really not designed to actually treat these diseases. They just happen to maybe have some slight quality of life benefit or some slight symptom reduction, but they're definitely not there, intended for the disease. This really strains, obviously, the provider relationship when it comes to rare disease patients and their providers. They have to really often stay resolute in the face of who is expected to be, the expert, right? A trained medical professional who can often come with either a different recommendation or a counter recommendation or a lack of knowledge or a lack of care. And staying strong and resolute and self-advocate in those situations is intimidating, right? You're talking about going up against healthcare providers that sometimes or making sure that they're really thinking of it coming from the right place, talking to the right people. The parent's role as the expert caregiver, right? We talk about being an expert in this disease. That's both the patient and the caregiver in almost every situation. And so, but that role as expert caregiver is rarely acknowledged by the healthcare system, which disrupts the relationship between the caregiver and the provider as well. Which in these early years of life, that's the whole piece, right? You have young infant and young children who are largely not able to do anything to manage their disease. And so this caregiver is having to do everything secondarily. Their relationship with the provider is just as important, if not, it supersedes it in those early years. Lack of knowledge by medical staff was cited by caregivers as the most common reason for delayed diagnosis. A lot of caregivers are frustrated by the fact that uh, they feel if the medical staff was more educated, they would get to a diagnosis faster, right, or more comprehensively, which means failure of treatment or denial of services. And due to the fact that many of these disorders really necessitate a particularly delicate balance to keep a patient in, relative health or relative normalcy, quick and poorly informed decisions can really have lasting and intense repercussions. And so I think there's definitely a hesitation by patients and caregivers to just make decisions flippantly or without the full information or without diligent monitoring after the decision is made to make sure it's actually working and not having challenging secondary effects. So that really requires being an intense medical self-advocate. They have to really drive every piece, as we've talked about here. And when it comes to that, there are a number of things that are almost always possible when, being a advocate for a rare disease patient or as a rare disease patient. You can ask for a specialist or specialists to weigh in, right? That's not a simple ask, right? We'll talk later about the fact that access to specialists and knowing how to ask for that, knowing who that should be, are all additional challenges, right? Additional things to navigate. But it is there. It should be there for you to talk to doctors about, getting a specialist who's an expert on some or multiple of the areas that are presenting the key challenges. And that should be honestly something being driven by the providers themselves, but it isn't always. Make sure you're able to reference past experiences and notes. Provide relevant context where you can. Provide historical context where you can. Call upon those patient and caregiver, peer communities, and those kind of historical message boards for context, right? Are others struggling with this? When they've navigated it, what has been the outcome? What are their recommendations, right? That's an immense pool of knowledge that often ends up being one of the only kind of well-suited sources of knowledge for many of these situations. And it's almost always going to be possible to ask for more time, right? To research a decision, to research the implications of it. And this is both for the patient and the clinician, right? I think there's often a feeling that you want to make a decision within a meeting so that you have the next steps to go forward. But if you don't feel comfortable with that, or if you're not certain with it, it's also fine to say, well, these are the questions that still remain for me. Well, I'm going to go back and research these. I'm going to ask the care staff to do the same, and then I want to circle back on this decision, right? I don't want to make this right now. So that's always a piece as well. When it comes to those specialists, obviously that they end up playing this, a very key role when it comes to rare disease, and that makes sense. You're talking about diseases that often have those implications in, specific systems in ways that are, in ways and in combinations that are unusual. And so you need specialists who you really know those systems and their interplay with others to come in and help truly unpack the full picture, right? And hopefully get to a full diagnosis and then an effective care plan with whatever is available right now. They should be more familiar with that, with rare diseases just in their discipline in general. And like they're more likely to have seen a patient or similar patients in their practice, or at least in their training. And they typically have an established network of kind of fellow peers who likely, have a patient themselves, or, related specialists who they can refer out to for those interconnected situations. And they typically understand that diagnostic odyssey a little better and the best ways to try to work towards a diagnosis. These are the people that are often trying to be those really granular detectives in these diagnostic odyssey cases and get to a diagnosis with these patients. Obviously, concentrations of these types of specialists and And this high level of specialty care typically come in the form of these things called centers of excellence. So you're thinking of kind of the named big systems that we've all heard of before, right? Usually in urban areas, and a handful of them around the country. And these do certainly offer an advantage in the fact that they typically provide kind of more holistic and specialized care for these rare disease patients. There can be, although there isn't always, as we've talked about, improved coordination because then you are seeing many of these specialists and getting much of this care within the same system or kind of within the same center itself. And so there is a hope and an improvement in coordination across these things and communication as well. And they're typically just they have a variety of complementary specialists in-house. So you're not having to go look for the next follow-up, the next test or whatever. They're reading the same results, they're working off the same kind of script, and they're in-house with each other, which is beneficial. Obviously, both seeing specialists and going to centers of excellence come with some challenges, right? These are specialists, so they're rare too, right? There's limited numbers, likely longer wait time for appointments and consultations. Insurance coverage may be variable, especially before a diagnosis, right? These are things that, insurance may not see as essential because they don't actually know what you have yet, right? And so there may be some resistance or some inability to get coverage on some of these things. And depending on if you're close to one or not, there could be a potential for long travel if some of these things need to happen in person. Sometimes you can get remote care where you can get testing done locally, and then those test results can get shared with these specialists, and you can do remote care. That's becoming more and more true since the pandemic, which is a key advantage. But travel can often be, a necessary piece of what this is. And all of that being said, there's still an immense benefit opportunity. Transferring patients to specialized care as fast as possible to provide the best medical treatment provides patient satisfaction, which makes sense, right? You're trying to get these patients to the diagnosis and correct care with people that are more familiar with their disease, have more just baseline awareness of the interventions and what they could be doing. And so it will hopefully get to better care faster. So when it comes to navigating that care landscape that we just walk through as a patient or a caregiver, there are some kind of best practices recommendations that can be highlighted. Obviously, like we talked about, keeping detailed notes, test records, other relevant treatment and testing information is incredibly important. You have a legal right to copies of all of your digital medical records, and so you are able to ask for those and kind of take them with you, make copies of it, physical and digital, so that you can be the one to share them if there's any kind of issue with getting those in an expedient manner over to another provider. When it comes to communicating outside the healthcare system, things like medical alert bracelets, cards, other quick methods of communication are really important in emergency situations, especially if a patient is incapacitated or unconscious, right? Getting clear communication of the high level important things about quick, trauma care, right, for these patients. How do you communicate that to stakeholders in those situations? Build a trusted list of advocates and experts with their areas of expertise included, and this can even include people that you suspect may be beneficial in the future, and you want somebody to be able to quickly call upon, right? You don't want to have to go and research a genetic counselor again. You don't want to have to go find a neurologist. As you run into these people, keep a list of who seems like they know what they're doing, right? Or not noted experts in either the systems you're looking at or the disease. It's incredibly important. And then keeping just a running record of questions. Many of the things you notice about the disease are going to come to your mind at the most random of times, right? Out in an event or in the middle of the night or something like that. And those are often the ones that are the most valuable to relay to the care team when they ask you, how is this disease manifesting, right? How is it affecting your life? What are the biggest areas that you notice it in? It's hard to call upon that list when you are in the moment and in the appointment, but having it slowly kind of accumulate over time, and then potentially even sharing that in advance of the appointments, so that the medical team can maybe review it in advance, can maybe do a little bit of reading to be better prepared coming into the appointment, just like you will be. That can be incredibly helpful and important, especially kind of in gathering kind of all those disparate insights that you'll catch at various times. And then another key recommendation is anticipating the transition from pediatric to adult care. As many of us know, losing your pediatrician, losing that pediatric specialist because of an age turnover is 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 already challenging, and then it's immensely challenging for these patients. And so, how do you prepare for the handoff, right? How do you prepare for as much continuity as you can between those providers, and asking your pediatrician who they partner with already, who do they trust in a space like this, is incredibly important. When it comes to cutting edge treatments and obviously things in development for rare disease patients, clinical trials typically offer the biggest avenue, if not the only avenue for that. Um, those can be found in the US on the clinicaltrials.gov website, and then other countries may have, other countries certainly have their own clearinghouses similar to this one, and they may be running trials in your disease. And again, we get back to the travel situation at that point, but there are rare disease studies being run all over the world, and so it's something that, again, patients and caregivers are responsible for monitoring on their own. Um, Other organizations like the National Organization of Rare Diseases, which is NORD, does publish um, a list of current trials or forthcoming trials that are relevant for rare diseases. So that would be another good one to keep an eye on. And there may be a possibility to kind of automate monitoring of some of those pages, such as NORD's page for mentions of keywords, right? So those of us who are good at kind of monitoring website automation or website monitoring and things of that nature could set up some keyword monitors on your disease of interest to hopefully make that not so manual, not so kind of having to regularly check on your own. But obviously, like a lot of other things, these clinical trials come with their own barriers. Whether or not you're fully eligible, travel costs, which are often covered by the trial itself, but not always. They can be somewhat decentralized, and there's just that lack of awareness of clinical trials. It's not very easily publicized or kind of monitored. So that's a summary of kind of healthcare when it comes to rare disease. I did want to talk more holistically about the patient experience. And as we've talked about a little bit from a big picture perspective, there is a huge financial impact. And that really does acutely hit the patient and their families. Financial impacts can come in the form of lost time at work, early retirement, or a limited, both career options or career trajectory by the nature of the disease. Specialty caregiving and accommodation can be incredibly expensive and may not always be covered. And that's true also for things like custom equipment and a specialty diet, which many of these things end up coming into play as, somewhat of a therapeutic for these diseases when pharma or device options are not present. And off-label experiments, like we talked about, and experimental treatments, early stage treatments are often not covered by insurance because they haven't been fully tested, they haven't been approved as, for that indication. And so there's lots of non-covered healthcare, things that will make either the quality of life better for the patient or may help them, test a treatment or be on the cutting edge of a treatment. Many of those things end up being not covered, along with kind of all of the other expenses that come with facilitating care. From a U.S. economic burden, it is also immense. There is something like 418 billion in direct medical costs, as you can see in things like outpatient and inpatient, as well as prescription medication. There's a 2019 estimate. And then from an individual cost, so indirect costs and non-medical costs, even larger at 548 billion of costs to the U.S. economy. And it goes back to those things like lack of ability to fully contribute to the workforce, forced retirement, healthcare services not covered by insurance that are being paid for in other ways, right? Whether that's through the government or through personal payment. As you can imagine, with all of these things and all of these challenges, also comes an immense and a diverse psychosocial implication to patients, caregivers, and families for rare disease. And obviously, awareness and accommodation has its own weight on those individuals. And then it also limits things like social activities, right? Field trips, sports, travel. It can disrupt learning, as we've talked about here, and often does disrupt learning, whether through a developmental disorder or just being absent for care of the disease, being absent for inability to physically participate. And it can affect other developmental milestones, things like feeding, sleeping, toilet training. Many, if not all of these, can be either minimally or severely impacted by the implications of the disease. Patients and caregivers bear that in a psychological toll. Inefficient access and awareness among healthcare staff and communities can result in symptoms being invalidated. Visible symptoms can result in social discrimination, while invisible disabilities and diseases can lead to more denial and disbelief by, authority figures and stakeholders, including, teachers and principals and coaches and other authority figures who are going to be even less inclined to believe, a disorder that they have literally no idea for, much less any understanding of. Additionally, schools and employers can fail to address things like accessibility needs, which is an added, psychological and physical challenge. And then there's just kind of a general othering of rare disease patients. Research has shown that also in psychosocial aspects of routine care are not often included in kind of the care plan. And it makes recognition and discussion with providers and stakeholders particularly important for patients and caregivers. Many of these individuals are not going to proactively think of this, or it's not going to be included in a rubric. And so again, the patient and caregiver really has to highlight this, give strong, relevant examples and drive that conversation. So as I'm sure many people can equate, rare diseases can often be linked with a full disability status or a partial disability status. 8 out of 10 people live with disabilities or with rare diseases live with disabilities. And so, up to 70% of those can be invisible disabilities, right? Where it's not clearly obvious from the outside what people are dealing with and why they may have that status. And it can be incredibly complicated, including having multiple key issues and fluctuating disabilities, like we talked about, right? Flare-ups, differences in stage of life, all those things come along with it. Disabilities are not adequately recognized, certainly among the rare disease community. I mean, this is true more broadly, but especially and equally true within the rare disease community. Access is limited and difficult to things like needed public support, recognition, full status, inadequate information about how to even apply. All of those things really block access for rare disease patients when it comes to disability status and the things that are implied in that. And then clearly it can limit participation, like we just talked about. And if you don't have that status, or if there isn't a requirement, legally, those accommodations may not be offered by something like a school or a workplace, which really can limit participation and success rates. So when it comes to that, rare disease patients and caregivers can hopefully lean on things like the Disabilities Act and other regulatory requirements in the spaces that is where it's possible. But even when it's not, I think it's really important for individuals to speak up and advocate for themselves for accommodation and adaptation. Especially if you have a full diagnosis and you can get a doctor's write-up of what that implicates and what that means, you may be able to access well-suited accommodation and adaptation from some of these areas just based on, a doctor's recommendation or communicating with those stakeholders to get them to fully understand what this means for the patient. And so when the regulatory law can be applied, great. And when it can't, self-advocacy and understanding and communication is incredibly important to still try to drive towards full participation or as much accommodation as is possible. So we've talked quite a bit about the caregivers here, and I do really often use patients and caregivers incredibly interchangeably because while they may not have the disease, many of them are carriers, potentially have other family members, and at the end of the day are the ones intensely helping these very patients that can often have very intense manifestations, right, in their everyday life. And so they have to share that burden of the challenges and realities of the disease with their kids, with their charges, with whatever that person means to them. They have caregivers in the rare disease space have an incredible reputation for resilience and advocacy. I mean, the parents who you see start up entire foundations and entire clinical trials for either their kids single treatment, N of one, right? Or that the disease that their kid has that has almost nothing in foundation around it, and they stand it up, right? They get dedicated, they dive in, they rally people around them, they fundraise. It's an incredible, incredible community. And, caregiver requirement is particularly acute in many of these pediatric onset diseases. They are clearly, doing basically every step for an individual who lacks, the physical nature, the communicative nature, the understanding, the ability to do much of any of these things for themselves. And then they're having to do it in a way where they have no physical input of their own, right? You can't feel the pain or the thirst or the hunger. You're just truly trying to read a person vicariously, and that comes with its own immense psychological toll, right? Self-doubt and challenge that comes with that. Um, some of the more intense challenges reported is obviously that management and vigilance of all of the implications of the disease, regulating things like hydration and calories without being able to sense that yourself, sleep deprivation, stress, frequent illness, and emotional exhaustion in the caregivers themselves, things like social isolation, loneliness, and dissatisfaction, including things like a limited or abbreviated social life or a lack of spontaneity due to the requirements of, that care or kind of the limitation of things like treatments or medical devices. And then always having to educate, right? Always being the educator, always being the advocate, being on all the time. That's all hugely key to the caregiver perspective. And unfortunately, that burden and the impact falls disproportionately on female caregivers. Research shows that mothers have a lower quality of life compared to fathers, especially in the psychosocial aspects. Women are more likely than men to blame themselves for their child's problems or see their individual identity threatened by the child's illness. In families with disabled children, the research has shown that the division of roles actually seems to be more pronounced, meaning mothers that take on a disproportionate role of caregiver, and that is associated with lower well-being. Even when men and women experience those same conflicts in terms of work and family roles, they're often interpreted differently with a stronger detriment to women. And shared caregiving did have a positive impact on improving the quality of life among women when it could be realized. So that's obviously as holistic of a picture as I'm able to present from a healthcare and a patient experience perspective. Coming out of that, I just wanted to close with kind of some high level recommendations and some resources for this space. So the support networks, things like patient advocacy groups, peer networks, caregiver networks are an immense source of uh, support, education, resources, all of those context, what to expect, all of those things. They're incredibly important to these rare diseases because it's typically the only group of people who have as close to a full understanding of what you're going through. And it really shows. And so those alone have the potential to improve quality of life and psychological impacts for both the caregiver and the patient. Uh, like we talked about, identify a trusted network and a resource network, right? Trusted providers, vendors, services, and then make sure that you know where and when to call upon them, how to communicate that to others that are helping care for the patient, right? Disseminating that amongst the whole care team. Things like we talked about, patient communities down to advocacy, research, right? Who are the researchers working in this space? How do you follow them and get a relationship with them so that when they get something that is moving towards clinic, you're on their contact list, right? You can be aware sooner. And because of the unique nature of this disease, local is amazing. If you have a local chapter, that's wonderful. It's rare, right? As we see in a lot of this. And so it has to often be regional, national, maybe even global, depending on the prevalence of the disease. From a documentation perspective, as diligent, detailed, duplicate, all those things, digital, physical, as you can, is likely going to pay off in the long run, right? That documentation is really going to help. And then self-advocacy, staying resolute in all settings, trying to recognize that, unfortunately, that's going to be one of the only ways that many of these things are going to be realized, is if you can drive for yourself, right? Drive for yourself, drive for your care, the person in your care, all those things. At the end of the day, I would say one of the biggest things is, rare disease patients and caregivers really need to trust themselves in their lived experience. They have a unique and expert level of understanding of the disease, and even their individual experience of that disease. And that is the hardest thing to communicate to people and the hardest thing for people to truly capture. And so leaning on that, trusting your gut, building your narrative, is what's going to kind of sometimes be the armor that is navigating being a rare disease patient, and it's an essential piece of it because that thick skin nature, that determination, that being resolute is often going to be the biggest thing that's going to get you to the care, to accommodation, to understanding, and it has to be a piece. It's probably one of the biggest. From a systemic improvements perspective, in the areas of patient care, improved collaboration and communication needs to happen, and clearly needs to happen outside of being a responsibility of the patient or the caregiver. That is something that systems need to get better at across the board, and especially when it comes to these situations. Integrating things like the psychosocial support into care plans for both patients and caregivers is incredibly important and has all kinds of opportunity there. And just improving rare disease recognition and training with it for providers, especially from a trauma-informed care perspective. These are all suggestions for the system more broadly, but definitely things that I would say patients and caregivers should advocate for, right? Changes they should advocate for. From a caregiver perspective, expansion and diversification of resources and respite services for caregivers. There's very few opportunities for caregivers to be able to fully hand off the responsibilities of taking care of that person, even for a short amount of time, and feel confident that that person is safe and cared for so that they can fully shut off and have a level of independence and a level of recharge. Those are both rare and they're often not covered. They're often not funded, by health insurance other than very small amount that's covered by Medicaid. And so expanding those offerings, seeing the important nature of what that does for the psychosocial elements of caregivers, and then funding it are incredibly important. Just in general, increase healthcare coverage for the costs of caregiving, right? The diet, the time, the medications, the devices, all those things. That specialists in the home, specialized therapy. There's so many things that come with this, and the care landscape is challenging to navigate. Sometimes designed to be, and there just needs to be better coverage across the board for things like this. Maintaining and growing those patient advocacy and caregiver communities that we talked about, they're so essential to as a resource and just a source of um, benefit to these communities, and so they need to be emphasized. And then, moving that diagnosis as early as possible and getting that psychosocial support are crucial for helping caregivers adapt, helping them be resilient. It's an essential piece. I did just capture a list of, by no means a comprehensive one, but a list of kind of the larger organizations in this space, as well as a few key resources focused on some of the things we talked about, like clinical trial discovery and some of the other areas. And with that, I'll thank you for your attention. I hope this was a beneficial and educational overview of the patient experience within rare disease. And thank you for your time.